To the October, again, good evening, everybody. Welcome to the October 16 episode of It's Our Healthcare. Let's do something about it. Glad you were able to make it tonight. We've got a good agenda, so I'll get to it pretty quickly. We're going to hear from Dr. Steve shortly. Steve Auerbach, there he is in the corner, waving his hand. He'll talk to us about the contrast that we're facing, Harris and Trump, drug prices, Harris's long-term care proposal, and generally we'll get into a conversation, hopefully, about Project 2025. We have a document for you, if you'd like. But let's first things first. Rebecca, could you want to introduce Dr. Steve, and let's get that started. And we'll have a Q&A afterwards.
Sure, it's my pleasure. Steve Auerbach grew up in New York City and received his MD and MPH from Columbia University. He completed a residency in pediatrics at UCLA and then started a career as a medical epidemiologist with the U.S. Public Health Service, first with the Centers for Disease Control and Prevention in Atlanta, Georgia, and then overseas. And then he worked with the Health Resources and Services Administration back in New York. Having reached the U.S. Public Health Service mandatory 30-year retirement in June 2019, Dr. Auerbach now spends much of his time as an activist and volunteer for single-payer and related social justice activities. He currently serves as the Secretary for Physicians for a National Health Program, New York Metro. He is the Treasurer for the New York State Academy of Pediatrics, Chapter 3, and he is a member of the Board of Directors for One Payer States. Welcome, Dr. Steve.
You're muted. You're muted.
I'm muted.
Steve, you got your mute button pushed.
Sorry. Thank you. Pleasure as always to join with comrades and all that. A little false advertising. So this is going to be sort of the drug prices, why drug prices too high in the U.S. Deep dive. It's sort of the academic type talk I give with medical students and medical residents. It won't be a Harris, Trump, Democratic, Republican specific thing. I have references for those at the end. That's not this talk. We actually put together, I was sort of the producer behind the scenes of the last New York Metro Forum, which actually did cover that topic. And I've got numerous references for that topic. And Tim shared with me your 2025 document, or document, which looks great. And anybody who's not on Mark Henney's listserv ought to be on Mark Henney's listserv, which is full of these things. But this is going to be a bigger picture deep dive. As always with my talks, if you'll bear with me, a ton of material, slides are available afterwards. You're recording this. If you wouldn't mind saving your questions for the end, let me sort of tell my story. And then anything I haven't answered, please, we'll do the Q&A at the end. Just write them down now so you don't forget. And it might be the case even that I cover it along the way. And with that and no further ado, let me go to share mode. All righty. Let's see. All righty. How are we doing? Am I audible and the slides are visible? Fingers up from Donald. Thank you. So USA, you'll notice I've got this red, white, and blue theme in a lot of my slides. And it's because I try to give talks to the already not converted. I also am coming from this US Public Health Service background and I always like to say that single payer is the most patriotic thing we could do. for all persons living in America. You know, education, housing, fair wage, just labor practices, all those would be nice too. But I consider single payer to be a deeply patriotic thing, and I'm not afraid to sell it on the basis of patriotism and liberty and justice for all and freedom and security. So US drug prices, the price is wrong. So I've got an outline here of what we'll be talking about. Just the usual notes here. And let's see, I want to get, forgive me, but I want to get you guys off the screen so I can see my own slides there. Okay. So disclosures, again, this is the same talk I give as a grand rounds or a CME presentation. No financial relationship with any commercial interests. I am on the board of directors of a nonprofit, nonpartisan educational and issue advocacy organization that you may have heard of. So moving right along, I'm not going to go in too deep a dive on single payer for you guys. You all know everything there is to know about it. But I just want to point out that on the one hand, one of the things that's not covered currently well and would be covered under single payer is comprehensive coverage for prescription drugs with no out-of-pocket costs, no co-pays, no deductibles. There's no reason for them. Skin in the game kills, as I'll be showing. And it's also where we get some of those savings from in terms of being able to negotiate the same prices. And so bearing in mind the big picture with regard to single payer, this will focus on the prescription drug price issue that we have currently in our system and going on from there. But again, single payer, it would be national health insurance or state health insurance with the New York Health Act. It's a change in the financing, not the delivery, progressively funded, using conservative buzzwords. It's security. Everybody always has it, regardless of any changes in their life circumstances. It's freedom to choose any doctor, any hospital, any pharmacy, no prescribed network, so greater freedom of choice for patients. You know, they often say, oh, single payer, it's going to be one size fits all. And yeah, but it's a really, really giant size. So, you know, it really does fit everybody. It's bigger than any current size. And freedom of choice to choose which health insurance plan you can afford to pay the premium, copays, and deductibles of is, I would suggest, no freedom at all. And very importantly, no point of service costs. Not a national health system like they have in the UK or the DoD or the VA. The US military, a well-known socialist communist organization, has a national health system. The delivery of healthcare services would be continued to be provided by the same mix of private entities and public entities it is now. And in fact, they would be competing, yay, capitalism, they would be competing to get you, the patients, services to come to them. So I would suggest it's the best of capitalism in that way. Meanwhile, here in the United States, we have a horrible bang for the buck with our system. You know, we had this horrible bang for the buck. We were at the bottom. If you look at that left-hand side, that's where we were when I was in college and medical school, where you can see that the United States was pretty much the worst in terms of life expectancy of any of the other rich capitalist democracies around the world, even back then. We at least, our lines were touching the others on the bang for the buck curve. And the excuse that was always given back then, that I heard repeatedly in both MD and MPH, was, well, you know, the United States, we have a unique history with importation and enslavement, kidnapping and enslavement of African Americans into slavery. We have historical racist disparities. We have more immigration and more diversity, allegedly, than other countries. And that's the explanation for why our life expectancy overall is worse. Now, it turns out that even back then, if you looked at, let's say, you know, white non-Hispanics compared to other countries, we were doing worse on a lot of these statistics. But one of the points here is the divergence of the curve since the 70s. And, you know, we had pretty much the same, I would say, racist disparities and immigration diversity. But somehow or other, despite that not really changing much, we've acceleratingly done worse since the mid-70s. And a lot of this could be attributed to the neoliberal, just as it took over the rest of our economic political system, with privatization, deregulation, regressive policies, financialization of everything, for-profitization of everything. This happened in a big way in the healthcare system, and I think it accounts for a lot of this accelerating divergence. Again, we do worse in preventable deaths. These are avoidable. This is a subset of all deaths that are considered to be avoidable and attributable to interventions, amenable to interventions by healthcare systems. And what you see here in the lighter peach is the United States was the worst amongst all the rich capitalist democracies around the world back in 2009, and 10 years later in 2019, just before COVID, all countries had improved, but we had improved the least. And so again, acceleratingly doing worse, specifically those causes of death amenable to healthcare interventions. And again, suggesting that, it's the United States, far from single payer being an outlier, a fringy outlier, it's the United States as currently is, which is the fringy outlier from all the other rich capitalist democracies around the world and doing worse. One of the problems with the proposals that are sort of on board with, say, the centrist or corporate or whatever you want to refer to them as wing of the Democratic Party with public option, is it remains a regressively funded system. And so what you see here for those folks who are, first of all, under the age of 65, not into Medicare, and also just over the Medicaid cut point threshold at the national level of 140% of federal poverty level. What you see here is that lower income people under both status quo in green and public option orange pay a much higher percentage of their more limited total income than does the highest income folks shown on the far right. So 8.4% compared to 2.6% by way of example of the two extreme points. So higher income folks with more disposable income pay a lower percentage, the definition of regressive funding. Under single payer, the curve is flipped, whereas under public option, it's shifted a little bit, but not inherently changed. Again, on the arguments of rationing, of course, as you all know, it's the United States that is actually rationing care. We just ration it on the basis of access, availability between social equity and financial equity to be able to access care. And this shows in the lighter blue the percentage of the lowest 20 percentile income groups across these different countries, how many self-report cost-related access problems to medical care. I want to point out in the darker blue, which is the highest 20%, that the United States is generally worse amongst our highest 20% income folks, does worse on self-reporting cost-related access problems than the lowest 20% in the other rich capitalist democracies. So our current system isn't serving anybody that well, except maybe the top 5 or 2%. Basically, we've had 40 years of free market for-profit reform, where the solution to the perceived high cost of the US healthcare system is to make it harder for patients to get and harder for physicians to provide care, by adding more and more for-profit middlemen to extract more dollars, whether that's Medicare Disadvantage, adding privatized layers of insurance schemes between public Medicare patients and doctors, managed Medicaid, pharmacy benefit managers, et cetera. It's all really the same thing. This concept, this neoliberal concept of let's add an additional for-profit bureaucratic layer that didn't exist before. And by doing so, somehow that's supposed to increase efficiency and decrease costs. Suggests that the logic is faulty, and it's been proven so for 40 years. We also have a higher unit cost for everything. So whether it's procedures or drugs or equipment or supplies or labs, pretty much every unit cost in the United States for anything healthcare related is higher than it is in these other countries. And again, diverting and extracting more and more dollars and more percentage going to profit rather than care. Limited networks, co-pays, deductibles going up, out-of-pocket costs going up, restricted coverage, prior authorization where the physician or other providers already said this is necessary. The insurance denies it, and they have to go through multiple layers of signing off before getting it approved, as well as increasing monopoly power, both horizontal and vertical monopoly, driving up unit costs, and everything investor owned, for profit, where if it's publicly traded stock companies, then they have a quarter on quarter need to increase the earnings and or profit to maintain their stock price. And if it's private equity or venture capital, it's even worse. Harms to patients, harms to doctors, etc. So the result over the last 40 years is worse healthcare and worse outcomes, and doing worse compared to peer-reviewed countries, and increasing aggravation for any healthcare workers as well. And as George Carlin said, I don't believe there's any problem in this country that no matter how tough it is, we Americans, when we roll up our sleeves, can't completely ignore. And that's pretty much what we've been doing, except for Bernie and Jamila and PNHP and NIPAN. And I would throw in Elizabeth Warren myself. So what's evidence is there that maybe we could do better? Well, here's an example of age-specific mortality rates. And I keep using mortality rates because at the end of the day, that's your ultimate outcome measure, right? Dead or alive. And if you look at these age-specific mortality rates, so what is the mortality rate for 15 to 19-year-olds? Number of deaths in that age group divided by the number of persons in that age group. And in the United States, we basically do the worst amongst all peer countries from ages 0 to 65, when magically at age 65, what I like to refer to as Medicare as is begins to kick in. And with Medicare as is, despite all of its limits, all of a sudden the United States begins to normalize and look like all of the other rich capitalist democracies around the world. And in fact, we do pretty well. So again, I'm often giving this talk to folks that are not already sold on single payer, and I want to offer them the possibility of suggesting what alternatives they might suggest. And again, following my patriotic theme, I want to suggest that, if they want to design a healthcare system and a healthcare financing system and administrative system, it ought to be universal, it ought to be simple, and it ought to be affordable. In other words, it ought to be USA. Now, drugs. We pay more than any of the other rich capitalist democracies around the world for the same drugs from the same multinational companies. How much more and why, and what are the consequences? So following up on Sesame Street, I would suggest that one of these prices is not like the other. So this is a standard, highly patented, only because it's using pre-existing drugs that have been out for a long time, but in a combination and a delivery system, so they're able to extend the patents, but it's available in these other countries too. And what you see here, denoted by each country's flag, is how much the unit price is in those other countries. We've got Germany and France, and I think that's either Australia or New Zealand, and the UK and Canada, and here's the US. And again, I suggest one of these countries is not like the other. So for the moment, let's take a look at how much drug costs have increased in the United States. So this is something that a very much not single payer supporting organization, AARP, which is not really an association of retired persons. It's actually their main business, if you look at their finances, is selling health insurance, including Medicare Disadvantage and Medigap programs. So AARP is mostly an insurance sales company. that then also provides as their loss leader some benefits, other benefits to retirees. Even they, however, because the insurance companies are not happy with drug prices, do this wonderful report on a regular basis, looking at what are for the brand name top 260 drug products each year, what's been the inflation rate. What you see here in the blue bars is the annual inflation rate for the top 260 prescription drug products in the United States, compared to, in the gold line, what the regular general inflation, background inflation rate is. And what you see is year on, year out, the brand name drugs and the generics are at several multiples of the background inflation rate in terms of their inflation rate. And again, these are drugs that have already been out there for a while. So that makes no sense whatsoever. And another way to look at it, looking at just a few of the absolute top drugs, we've got 49 top-selling brand names, some specific ones here, over the 5 years from 2012 to 2017. And over about 44% of them had more than doubled in price. Over 3/4 of them had increased by more than 50% just in that 5-year period. And again, they've already been out for a while. If you buy a cell phone or a computer or most other devices over the course of 5 years, the prices go down. But in drugs, they go up at a much higher rate than the inflation rate. Again, comparing what is the drug price for the United States compared to other countries, on average, over 3.5 times the rate, as you see in the dark blue there, and roughly, somewhere in the high 200% to 300%, the US drug prices are higher than in these other countries. And again, this is from that well-known communist organization, the Rand Corporation. That's sarcasm. Another way to look at it, comparative drug prices for US, Canada, France, and Germany in 2015 for some of these leading drugs. This is in JAMA, peer review medical company, and again, showing the flip side, if you will, of the average for the other countries compared to the US is, roughly minus 2/3, minus half the price, etc. Another way to look at it is per capita spending on drugs in the retail setting only, comparing the US to these other countries. And again, per capita spending on drugs far higher in the United States than these other countries. Another way to look at it, again, percentage of international GDP per capita on average drug prices that we're paying in our public sector under Part D, where they're not allowed to negotiate the prices compared to the other countries, all of which obviously, of course, because they're not stupid, negotiate the prices of the same drugs from the same multinational companies that are selling to all of these other countries, and we're paying many, many multiples of those prices. People often like to look at Switzerland as somehow this more capitalist, a little bit more like the US, less reform system. Just want to point out that under that quote unquote more capitalist system in Europe, they're nevertheless somewhere around 1/8 the price, if I'm reading that right, 1/6 the price. They're the ones that have the ratio of GDP per capita compared to the US. That's the greatest savings. It's ironic, shall we say. Again, US Medicare Part D is paying more than the adults for other countries. So this is looking at specifically sick people. So it's over 65s who have both heart failure and diabetes. And what's the outpatient spending for these older adults as they cycle through a hospitalization event, which is when we're able to capture the data. And again, what you see here is for these folks who are on medication for their heart failure and diabetes and are over 65, paying way more than in these other countries. And again, it's not because the other countries are somehow skimping on not prescribing the drugs for them. That's not where the savings are. In fact, what you see here in the blue is the United States is, on a little bit below average in the number of unique drugs prescribed, but far higher in the blue, and far higher on the amount being spent. So once again, less bang for the buck. Health industry profits in the United States, pharmaceuticals are way in ahead. I mean, you could basically say they're number 1, 2, 3, and 4 on this list before you even get to the insurers. And we medical providers and other healthcare providers are clocking in way down at the bottom there. Little misleading only because the insurers, pharmacy, and lab benefit managers are all the same company now. So one of the arguments that the the drug manufacturers make is, well, we need to make all of that money. We need to sell it at these high costs because we're plowing that back into research, and you want your new drugs, don't you? So the reality of the research argument is, well, it's basically a lie for a variety of reasons, one of which is according to their own public filings. They spend 13% on research and development in total. And as I often point out to the physicians and scientists when I'm giving this talk, the drug company's definition of research and development is probably a bit broader than what you might think of in terms of research for a new molecule, a truly unique new molecule to combat a disease that doesn't have adequate treatment currently. Again, most of it's, other things, marketing, administration. You've all seen the drug ads, of course, and manufacturing, profit, taxes. Would point out that, in fact, the drug companies are spending more of their revenue on stock buybacks and dividends, shown in the second column from the right, than they are in R&D. So they're literally spending more in financial gaming of their stock price and dividends than they are on research and development. It's just obscene. And, when we were debating HR 3 back in 2021 and 22, these amounts that they were doing on stock buybacks and dividends was far in excess of the amount that the American taxpayer would have saved had HR 3 gone through as originally conceived. In fact, the pharmaceuticals, again, same companies selling the same drugs all over the world, are making huge excess profit strictly in their United States market, strictly because we don't negotiate or regulate the drug prices the way every other rich capitalist democracy around the world does. And basically, they're making more money in the United States on any given drug than they are in the entire rest of the world combined. It's simply an obscenity. The excess profit that they're making here. Remember, they're not selling those drugs in any other countries unless they're making some profit, which gets to the point of, in fact, pharma has a higher return on revenue as a sector than the rest of the Fortune 500, roughly twice to thrice the return on revenue of the other Fortune 500 companies. Remember, unlike the health insurance companies, which we essentially want to put out of business, we don't want to put the drug companies out of business. I mean, I like having my statin. I like having my blood pressure medicine. I like having, and my lipid cholesterol medicine. I just want to pay the same fair price, allowing a fair profit that the drug companies are selling the same statin and the same blood pressure medicine in France and Sweden and Canada and Germany and Switzerland and New Zealand and Japan and South Korea. Basically, the United States is subsidizing an excess profit by pharma compared to the normal profits that they're making by selling the same drugs in all the other rich capitalist democracies. We are the only one that doesn't negotiate prices. So that's multiple reasons why the whole research argument is a lie, but would also point out that when it comes to actually having the invention of a new molecule to make a truly new drug, all the research, all the basic science research is publicly funded. Every single new drug that has come to market, excuse me, problem here, calf. Every new drug that comes to market has its origins in publicly funded taxpayer NIH granted research. The amounts that they claim for a new drug coming to market are lies, as published in independent peer review, as shown here, and also by the Congressional Budget Office. Sort of your go-to for mainstream normative political economic analysis from Party Line, see Congressional Budget Office. Most of what they're calling research and development, in fact, are incremental line extensions of existing molecules. So a new dosage, a new delivery system, various combinations of existing drugs, et cetera, et cetera, et cetera. And it's the American taxpayer through the NIH that is the major source of biomedical research. And I point out the equivalent to Germany and the UK and so on and so forth. So the Pfizer COVID vaccine was, as we know, actually developed with German taxpayer money principally, just as Moderna was with American taxpayer money principally. And even pharma acknowledges that about $1 out of every $3 is spent on drug research is actually coming from the American taxpayer. And we contributed to every single new drug that has come out. That doesn't even account for the fact that's just the NIH grant money, taxpayer funded. That doesn't even include the tax advantage dollars that's going to all of these ostensibly nonprofit entities, research foundations, university medical centers, patient organizations of various sorts, and other R&D tax credits, all of which are basically courtesy of the taxpayer, as well as the public funding that comes from other countries. By the way, MRIs and CTs developed in the UK. So surely if $1 out of every 3 research dollars is being spent, comes out of American taxpayers, surely those taxpayers ought to be sharing in the profits, right? We help capitalize the research, and the research the drug companies say is the excuse for their making their big profits. So surely we should be sharing in those profits, right? Well, we used to, but thanks to the Bayh-Dole Act back in 1980, we no longer do. I don't need to tell you folks that patent rights are not actually rights or something inherent state of the universe. It's intellectual property laws created and defined by the government. There are no actual libertarians. People claim to be libertarians absolutely want the government to enforce property rights, including intellectual property rights, with the courts and the police and the jails and the prisons. So prior to Bayh-Dole, we were able to share in patent rights. After it, we're not. And the timing was very specific. It's when we had the first genetically engineered drugs about to come onto market. This is when we switched. It was already in the pipeline, which is why they needed to do it right away, for when we were switching from pig and cow derived insulin to human gene insulin being developed, where they could insert the gene and into some other entity and spit out human insulin. And knowing that was on the market, the drug companies made sure to change the law. This whole business about margin rights, where if they don't sell it on reasonable terms, then the government could march in and grant licenses to other manufacturers or fix prices, was sort of the, well, supposed to be the escape clause. Unfortunately, it's never been actually used. And it's nonsense. There's a wonderful article that I'm referencing, that I have the reference for here, from The Intercept, that does a wonderful retrospective deep dive into the Bayh-Dole Act, if anybody's interested. Industries constantly trying to even weaken the protections even more so. Whenever the margin rights get threatened to actually be used, they start trying to propose new regulations and lobbying for it. Patent abuse, just absolutely horrendous. Humira, as you may know, is used to treat many inflammatory conditions. It's an immune modulating agent. for arthritis, psoriasis, Crohn's disease. I have several close relatives with Crohn's, for whom it's very helpful. It's been one of the top selling drugs in the world. Same drug, same molecule. It's had 247 different patent applications for it. Basically, their goal is to delay any competition in any generics for as long as they can. Sometimes referred to as the Walt Disney Mickey Mouse way of patent law. Needless to say, there's lots and lots and lots of lobbying because that's how we do things in American democracy. Pharma and device manufacturers are the #1 lobbying entity, according to this chart. Insurance is further down, and you'll notice the health professions, the dreaded AMA, is way lower down. Pharma way up there, ahead of real estate, ahead of business associations, ahead of oil and gas, at least when it comes to sort of publicly declared lobbying. And again, so many lobbyists for so few Congress people. And of course, they're all revolving door types, former government employees, principally. This has been a heavily bipartisan thing where the lobbyists for both the insurance companies and the drug companies circulated in and out from the Clinton administration back into lobbying positions, and then during the Bush years, then came back during the Obama years to actually write the ACA. So the other problem is that breaking the law is a routine cost of doing business. They get big fines. So actually, you know, they get caught reasonably often breaking what is the law for promoting their drugs, and they get fined. No one ever goes to prison, of course, so no individual human being is ever held responsible, and therefore it just is another corporate cost of doing business. And for the executives that are pushing to do this, since they're not going to actually go to jail, they're never actually held responsible as human beings. Their human being makes the choice. Corporations do not make decisions, people do, but people are never held responsible, only the fictional corporate entity. So that's all terrible, but wait, I can tell you it gets worse. Pharmacy benefit managers, this wonderful new invention that came up a few years ago, did not exist before. So what if I told you that what we need to do is insert some way to negotiate the prices on a large group level with the drug manufacturers that are selling the drug primarily? We need to negotiate those prices. Well, that's exactly what us single payer folks have been saying, is that government, as part of the government insurance scheme, should negotiate the prices from a position of monopsony where the buyer has the monopoly, just as every other rich capitalist democracy around the world does in some fashion. But this being neoliberal America, what they did is, no, let's create a new for-profit entity, a new corporate for-profit entity, and insert them in the middle of this negotiation process. So we've got the drug companies selling the drugs. We've got the insurance companies partially paying for the drugs. We have individuals, patients getting the drugs and paying some part out of pocket. And we've got the doctors prescribing them. So let's create a new entity called a pharmacy benefit manager. And as an independent third-party for-profit entity, it's going to negotiate on behalf of the insurance companies, negotiate the drug price is down. And as part of whatever savings they negotiate the lower costs up from, whatever savings they create, they'll keep some of that as their profit because that's their capitalist incentive, and they'll pass the rest of it on to some balance of the insurance companies and the patients. That was the concept. Complete and total nonsense from day one. So this is how it's supposed to work, okay, with the PBM, pharmacy benefit manager, somewhere in the middle there, negotiating between the drug company, the wholesale pharmacy, the health plan that's paying, the patient, etc. That's how it's supposed to work. Ridiculous on its face that the PBM should just be the government negotiating prices instead of a new administrative for-profit layer in the middle. But wait, it gets even worse, because guess what happens when the health plan, the wholesale and retail pharmacy, and the pharmacy benefit manager are all the same company? There's no incentive to actually reduce costs, because whatever savings they get on one side just is another piece of this, another column of the spreadsheet for the other company. So yes, they want to negotiate prices down in terms of the drug manufacturer and patent owner. But as far as they're doing it on behalf of the patient, the wholesale pharmacy, or the health plan, it's all the same company. And so it basically just becomes another profit extracting center. And it's really just a matter of accounting games, where the payments on one side just become the charges and overhead on the other side, and you're just shifting between divisions. And the big three are now the insurance companies also have 80% of the PBM market share. So just another example of why adding additional layers of for-profit middlemen doesn't increase costs, doesn't decrease costs, does increase them. And it's the same as Medicaid managed care. It's the same as Medicare Disadvantage from that point of view. Definitely sucking the teeth of the American taxpayer here, and not even to the benefit of the drug manufacturers. That's how bad it's gotten. So PBMs are now taking 41% of Medicare drug dollar. So Medicare Part D drug dollar, taxpayer money, intermediaries as a whole between the drug manufacturer and reaching the patient are sucking out 70% of that dollar. The drug manufacturer is only getting 30%. You saw what their profits were. And by adding in the pharmacy benefit manager on top of the pharmacy and the wholesaler, you've just sucked out more money. So what's the impact of all of this on all of us? Again, international comparison of who is actually rationing care. The United States has a much higher self-reporting rate of adults who are not sticking to the prescribed drug therapy due to costs. So international comparison of people skipping drug doses because of cost, much higher in the United States than any other country. And I would point out that Canada is usually the second worst on a lot of these things because of the way their particular system works. Canada's system, when they brought it in, did not cover outpatient prescription drug prices. And so actually what we think of as sort of the health benefit you get through your employer for insurance as a whole, in Canada, their version of that is that the outpatient prescription is a benefit, is the worker benefit that you get as your employment benefit. So cost-related medication non-adherence is our official term for this. And again, you see much higher rates in the United States than in the other countries. It's, of course, higher, follows kind of a dose curve. So folks who have no insurance, or have no insurance, or uninsured with a coverage gap, or uninsured all year, are higher by each category compared to those who are insured and not, quote unquote, underinsured. Again, just the obvious that if you're paying more out of pocket, you're more likely to not fill the prescription. Copay is skin in the game. This was a term that came up a lot with the ACA, this idea that, gosh golly, one of the ways we have to make sure that individual patients are not wasting money and abusing the healthcare system by getting care that they don't really need, even though all of these things are actually gatekept by the healthcare system. So the doctors and hospitals are really the gatekeepers. You're not getting a prescription drug if you're not getting a prescription. You're presumably not getting a prescription if your doctor's at all ethical, and the onus ought to be on the doctor, not the patient. You're not getting the prescription unless you need the drug. In which case, why should you be paying for it above and beyond out of pocket as a way of somehow or other avoiding abusive overuse? It makes no sense. But we do see here, and this again was by the National Bureau of Economic Research, government entity, where for cohort of folks where they had a $10.40 increase in the copay per prescription, the amount they had to pay when they pick up the prescription, when they get the prescription out of pocket, in first year Medicare enrollees, what we saw was a $10.40 increase. Doesn't sound like a lot per prescription, resulted in 12% less filling of the statin prescription, as you see on the left, and X, Y, and Z, various amounts less for each of these different categories of drugs. And over the course of the year, resulted those that had the higher copay, in addition to having a lower percentage of filling the prescriptions, had a 33% higher mortality rate. So again, the ultimate outcome, saved money, killed people. Copay, skin in the game, multiple sources, multiple studies showing the same thing. This is 5 different studies. The first one is the one I was showing you before on a separate slide. The one that's the most horror-making, I think, is number 5. So this is pediatric cancer survivors. So they've already survived their initial bout of cancer, but they have ongoing medicine, prescription medicine needs, obviously. This is a group that there is certainly no issue of having abuse of overuse. These are kids who've survived an initial bout of cancer, for God's sakes. And again, those with less copays, better coverage, had lower non-adherence, as it's referred to. Again, persons with diabetes, they need their insulin or they're going to die, et cetera, et cetera. And again, there's a dose effect, right? So the higher the copay, the odds of filling a prescription go down. Very direct. This is a chart that Dr. Lewis came up with for the number of different steps between the patient visiting the doctor and the patient receiving the medication. They identified 26 different steps that were required, going through prior authorization to get a prescription refill, a drug the person was already prescribed previously through the Cigna plan. The absurdity of this diagram is the American healthcare system. As bad as it is for everybody, it's, as always in the United States, there is a racial inequity component to it. These are some reports on basically how systemic racism and farmers' racist price gouging is killing Black and brown folks, even in excess of it's killing white folks. Alas, we doctors are part of the problem. Most doctors take money from the drug and device companies. All of the academic, high-powered academics take money from it. One of the reasons we have trouble breaking through with the highest level academic medical centers supporting single payer is the CEOs are all on the take. Again, just like drug companies are actually run by individual human beings. No company is making a decision. People are making a decision. Individual people are in charge of these academic medical centers. And what you will note here for all of these academic medical centers, nonprofit entities, and their CEOs, if you look at the second from the right column, the board pay, that's how much they were getting in 2017 to be the CEO or director of these companies. But it's that status and that position that then allows them to also take consultant fee money from the drug companies, often in share value prices, so that they are now not only taking the money from the drug company, but they are tied to and biased to maintain those stock prices because they've been paid in share value. And so basically they're all bought off. So drug company payments and doctors, we have the detail people that come out to the offices and tell us how great their drug is, and they're all supposed to be independent. They all show these wonderful, ostensibly peer-reviewed papers, and all the doctors will then tell the activists, oh no, this isn't changing our behavior at all. It's just providing some information and a free lunch. But of course, what's really happening, and the drug companies know this, is that in fact it is affecting brand name prescription prescribing behaviors. And the drug companies wouldn't be doing it if it wasn't. There's a huge impact on hospitals. And again, another reason hospitals ought to support single payer is hospitals are corporate entities that employ people. So their employer health benefits would be much less. So the big hospitals as an employer would be paying much less in health insurance premiums as a benefit for their employees. They'd also be saving money because the drugs that they dispense would cost much less. And so all the drugs and devices that hospitals have to purchase cost them money. They've been heavily impacted as entities with a balance sheet in how much the drugs, increasing in drug prices, is costing the hospitals. And again, far outpacing the inflation rate, and frankly, outpacing the reimbursement that they get from the insurance companies. And this is one of the things that's putting a great deal of financial strain on many hospitals. Again, monopoly power has been a huge issue here. So for a lot of drugs where the initial company that developed it and had it for a while then sells the patent to another company, typically a venture capital, not real drug company, and the latter then jacks up the prices by multifold. So just some examples on the inpatient pharmacy side, Daraprim had a 50 times increase basically over the course of the year, 1 year, went up 50 times the price when it was bought by from the original company, then by Turing. Similarly, IV acetaminophen Tylenol by IV, a specific use thing, occasionally went up 2.5 times. Again, generic drug, but under patent because of a specific delivery concoction and mechanism, et cetera, et cetera. And again, the gaming of patents under the guise of FDA reform, rebranding of older drugs back into patent, a variety of things where it's turning around and getting monopolies on generics and basically having generic, what's called generic capture, and you don't get the benefits of a generic actually resulting in reduced prices. So doctors, over 92%, according to the AMA of physicians, report prior authorizations, including for prescriptions, having a negative impact on clinical outcomes, as well as just being aggravating additional paperwork for us. And I can guarantee you that every single practicing physician and other prescribers like nurse practitioners have horror stories about this. And then there's the frontline pharmacists. So first of all, the mom and pop individually owned pharmacies gone out of business with monopoly power from your CVS's and Walmarts and Walgreens and what have you. But there's also, as patients go to that front desk and try to get their medication, who are they going to get angry at? They're not getting angry at the CEO. They're getting angry at that person manning the first front desk. Forgive my sexist language, personing the front desk. And so this, especially with COVID and people, yelling to get their COVID vaccine and then yelling to, stop selling the COVID vaccine if they were anti-vax, and those frontline pharmacists absolutely getting burnt out. People who used to be individual entrepreneurs now working for big companies, being treated poorly, those frontline pharmacists, some movement to unionization and so on and so forth. But again, everybody's being driven crazy by the system. So end of show, what do we need to do? Well, under single payer, the whole point is the buyer has some monopoly power. That single payer government entity, whether it's the state of New York or the United States would have a consolidated power to negotiate for lower prices. And we could certainly look at the benchmarks for what all of those other rich capitalist democracies around the world are paying and say, yeah, we'd like to pay the same amount as they are. So that's the cost savings at the system level. And then for the individual patients, we really just need to remove point of service costs on prescription drugs, no copays, no deductibles. If the doctor or nurse practitioner says you need it, just get it. So until we get that, certainly reducing drug prices is one of the most popular bipartisan things, bipartisan in terms of the populace, not in terms of the politicians. So people, regardless of how they vote in actual elections, strongly support reducing drug prices. There's a variety of ways to do that. Let existing public programs negotiate prices, the big one being Medicare, the example being that we already do this for the VA and the DOD and Medicaid. And the whole point of what prescription benefit managers were ostensibly supposed to do. We get a little bit of reform with the what came out of HR 3, which was now known as the Inflation Reduction Act, IRA. When I was growing up, IRA had a very different meaning. But we need to be very careful in the reforms that we get, because the reform we got was a price cap, was not a true price cap. What we got was a copay cap if you have insurance coverage for the drug. So if you don't have insurance coverage for the drug, you're not getting any savings. And so we need to be careful. Is it an actual price cap? They can't sell it to anybody for more than X. Is it a cost cap? You can't charge insurance more than X. Is it out-of-pocket costs? You can't charge a patient more than X out of pocket. Or is it a copay cap, which only applies if you have insurance that covers the drug? Other things, allow importation from the other countries. Well, why not just negotiate the same rates? Actually exercise the buy-dole march-in rights. Go back to at least allowing taxpayers to share in the patent profits. Stop abusing the patents with lookalikes and generic capture and things like that. Reduce the monopoly power, break up the monopolies, let there actually be actual competitive capitalism instead of monopolistic finance capitalism. Mandatory generic manufacturer, when things are off patent, require there to be generic manufacturer, and so on and so forth. The last reference, there's numerous references at the bottom here. The last reference there is actually just came out on October 4th and from the CBO, the Commercial Budget Office. And it's a long list of what are sort of considered to be possible within sort of the CBO allowed realm of thinking for ways that we could reduce prescription drug prices. And I am done finally.
Well, Steve, thank you. That was provocative and comprehensive. We were over time a little bit. I want to give you some notes for everybody who's here before we leave, but are there any questions for Steve? Just click the reaction button and look for the raise hand button. Still processing, right?
So love Ozempic. What was the figure? It's now outpaced the rest of the countries. Is it Denmark? It's like single-handedly responsible for increasing the GDP of Denmark by some X multiple.
Consequences have consequences. Well, I have one quick question. Or maybe it's just a thought, because looking at what we can do next, because all through the presentation, I was thinking, oh my God, this is massive. This is governmental. This is corporate. This is. Maybe we can take a look. Once we get the slides, we are going to send everybody the slides afterwards. Once we take a look at it.
We'll share the slides. I also have your recorded version. There's an earlier recorded version I've got up on YouTube. I've got a YouTube channel where I give most of my talks have been recorded at least once recently. Both the big single payer talk, this one, and some on racist health disparities.
So my challenge, I guess, to all of us is to look at that back page. What I was doing is looking at the back page and saying, which of these might I have some input to? I
Yeah.
call my congressional representatives, my senators, my state representatives, along with pushing the healthcare and the New York Health Act. So I
mean,
challenge
depend-
everybody.
Yeah. The doable one that ostensibly came close, it depends, I guess, how cynical you are about the US political system. But, you know, with maybe 3 Democratic senators opposing it and maybe somewhere in the range of 4 House members, but including from some key committees, HR 3, which ostensibly was, you know, strongly backed by Pelosi and Schumer, you know, small Democratic majorities that we had between 2020 and 2022, strongly backed ostensibly by Biden, came this close to passing, you know, in its original form, would have been Medicare Part D can negotiate prices across the board, right? That was the ideal. What we got was a very slow rollout of Medicare Part D can negotiate prices for a handful of drugs,
right,
starting with insulin.
right. So that's a start.
I'm sorry?
That's a start.
It's a start, and it's also the model, it's sort of the starting point model of what's considered in the Beltway to be politically feasible.
Right, okay.
And you can sell it as good for patients, and you can sell it as good for taxpayers.
Right, good point. All right, so the presentation will be in the notes.
Yeah.
Before we leave, thank you very much, Steve, for your time and your energy on this. This is really, really very, very important. A couple of notes. We've got Prop 1 on the Proposition 1 for New York State on the ballot. It's on the back of the ballot, so I assume you all know that and telling all your friends and door knocks. We've got I'm sorry. Oh, the newsletter continues. The Tim Fresk has joined us. Hi, Tim. Thank you for coming. He writes a newsletter every week that I get, and I put it into the website, the NIPAN.org website, and it's fantastic. It's a great read every week. It's in under, you have to search a little bit. It's under issues and resource, healthcare and resources. So once you get down there, you can find it, and it's really very comprehensive. Ting, did you want to speak for a minute about WFP?
Yeah, just a minute, because we are over time. Please, everybody, if you're going to vote for Harris Waltz, please vote on the WFP, the Working Families Line, row D. It's really important because thanks to a gift from Cuomo on his party, we have to get 250,000 votes on that particular line in order to continue being a party. And actually being the party that the Democrats should have been, but aren't anymore. So that's for that. Thank you.
Thank you for that. And one last note, we were planning our November 11 meeting for the next monthly meeting. And we're looking at the possibility of what we call honoring our champions, the legislators and senators who are backing or co-sponsoring the New York Health Act. And we're looking at highlighting them next month. But stay tuned. We're not firm on the plans yet, but high hopes, good possibility. Point out the champions, shine the light on them, let them talk to us about why it's so important to them. Okay, everybody good?
Can I ask a question? Are we getting ready to sign off?
Yeah, Tim, but go ahead.
I'm welcome to, I got nothing else to do.
Yeah,
Right.
I put my email in the chat if anybody wants to digest direct. My question is, there was some chatter, and I was participating for a while in DSA about doing some action, trying to promote something at the state level, which sounded interesting. I didn't really understand it too well, which was to increase the pool for state pharmaceutical purchases, which apparently exists already because of the state Medicaid program, but to try to increase that through some kind of legislative action. And it seemed like an incremental measure that might have pushed things in the right direction. So do you know anything about that? And does that sound like a good strategy to you?
No, I don't. Yes, it does. The one I'm aware of has been because the persons living with type 1 diabetes are well organized, because it's, you know, literally short-term death for them. And the abuse of insulin prices was just so obscene. So what's referred to as T1, the type 1, the T1 lobby was pretty well organized, and they've been pushing at state level to get the prices down, prices capped, and going beyond whatever we did get in the IRA. I mean, they started before the IRA passed. And I know that there were bills in the New York Ledge for that. And so that would be a model of, if we can do it for one drug, why not for all of them? And again, that would be an out-of-pocket cap regardless of insurance status. So it'd be something like, $30 a prescription or $30 a month or $30 a year, or whatever.
It sounded promising to me, just because in my readings of, articles from all over the country, this is an issue for every state, including the ones, of the bright red variety. And so it seems like the sort of thing that could attract a broad
Right.
support. And at the
Medicaid,
state, sometimes
Medicaid pricing is very complicated. The cost of Medicaid, and it gets involved with something called 340B program,
right.
which is its own controvery.
Yeah.
Because on the one hand, it's vitally important for a variety of reasons, and on the other hand, it's been massively abused by bad actors.
Yes, but this is somewhat different because it's about using the state's
the state's funding.
Right.
Yeah, the problem is that what the states are all going to say is we're broke, and the states are all going to say we need to save money. So unless we can negotiate, unless they can do the savings by negotiating the price, as opposed to what we usually do is subsidize the excess profit in order to provide it for the needy. So, I mean, that's what
I like the purchasing pool, because that's exercise your bargaining power as a main purchaser. So anyway, thanks.
Yeah. I mean, I just want to point out, I mean, the whole liberal fight for things like the ACA premium support, right? So we go, even after the ACA passed, we go through this periodic crisis of, the premiums are going up, so we need to improve the premium support so people can afford to buy on the ACA exchange. And of course, the mainstream folks never point out that all this is taxpayer money to support excess profits by the health insurance companies, rather than, tell them to stop gouging us at 18% of overhead instead of 2% of overhead. So we're sort of stuck, right? Because we don't want to actually kick people off the ACA, so we boost the premium supports, which is just taxpayer money going to Aetna.
All right, Tim and Steve, thank you for that exchange. One more note before we leave. There is in the chat a link to what we call the Project 2025 document. Julie and I worked on that a little while ago. There's a one-pager in there that shows the impact quite specifically of various pieces of the healthcare part of that 900-page document on the healthcare system and on the possibilities for the New York Health Act. So it's a valuable tool. So download it at will. I'll leave the link open here. So in case you want to copy it, feel free. And with that, we wish you all a good evening. See you next month.
One thing, Ting, I had sent you had asked me about Harris and the long-term care proposal, and I did send you my thoughts on it if you wanted to include those.
Great,
Or anything
thank
else
you.
have above and beyond.
Yep, thank you.